Hey everyone, welcome back to my channel. So in this video I'm gonna be showing you how MCA Stroke presents, and this is a series of videos. I'm gonna be doing each vessel alone, so let's get started. Alright guys, so this shows you the distribution of vascular territories. So the MCA that we're going to talk about today, as you can see here, supplies the entire, or most of the lateral aspect of the cortex. That's a great deal of the frontal, temporal, and parietal cortices, with a lot of important areas I'm going to be showing. And medially on cut section here, guys, you can see that it's supplying the internal capsule. That's the area I'm most concerned with at the moment, and this would be through its smaller branches. So we have cortical branches over here. These can be occluded and cause cortical strokes, or you have capsular branches right here and supplying the thalamus and basal ganglia, stuff like that. So it can cause capsular strokes if these branches are occluded. So we have different possible presentations according to which branch of the MCA is affected, as I mentioned in the previous video. So these areas, guys, are the important ones that I mentioned regarding the MCA. If you take a look here, we have the frontal lobe, the premotor cortex, and the entire motor homunculus along this area will be affected. The primary somatosensory cortex in the parietal lobe, and the sensory homunculus part of the face and upper limb going here will be affected as well. Plus the Broca's area or motor aphasia, and the Wernicke's or sensory aphasia, and these are, guys, the areas supplied by the middle cerebral artery. And so you can expect that if a cortical branch is affected, guys, that the person will have monoplegia of the upper limb and face, and impaired sensation of the upper limb and face, because the motor and sensory homunculus over the lateral aspect of the brain are supplied by the middle cerebral artery, right? So I'm gonna be talking now, guys, about what will happen in case of a left MCA stroke. We already mentioned there's gonna be a sensory deficit and a motor deficit over the distribution of the upper limb and face, accordingly, as you can see here, to the primary motor cortex, primary sensory cortex. So that's contralateral hemiplegia and contralateral hemisensory loss, with more affection of the upper limbs and face. You can see here that there is more dense monoplegia or more dense affection of the upper limb and face than the rest of the body with MCA strokes, because this is the area represented here on the homunculus. I'm going to show you next why the rest of the body is affected in a moment. And then we also have, guys, the optic radiation going through the temporal lobe and the parietal lobes, and that is supplied by the MCA as well. And so the person will have affection of one side of the visual field. So if this is a left MCA stroke, they're gonna have affection of the right part of the visual field. So if this is right and this is left, and I have a left MCA stroke, so I'm gonna eliminate these parts. We're gonna injure these radiations going in the temporal lobe. Those in blue, guys, represent the right visual field, as you can see here. And so look at this. It's gonna be leading to right homonymous hemianopia, because I injured the optic radiations on the left side supplied by the left MCA. So the right visual field, guys, would be impaired. And that's what the person will be looking like, the right part of the visual field affected. What else, guys? Because like I said, the speech areas, Broca's, vernix, and the fasciculus conducting between them, allowing repetition of speech, called the arcuate fasciculus, are all supplied by the MCA. So this person will have aphasia, motor and sensory as well. So you can see here that the person is stuttering. They cannot seem to bring the words despite normal motor function of the speech muscles, because the speech muscles are supplied by the cranial nerves, which are not affected here as they're bilaterally represented, the cranial nerves 9, 10, 11, and 12. Rather, even though the person has intact motor function of the muscles of articulation, they cannot seem to speak because of the speech area affection. And this impairment of higher brain functions proves that this is a cortical stroke. All right. Finally, guys, the frontal eye field area in the frontal lobe, the one responsible for horizontal conjugate gaze deviation, is going to be affected. So if I want to look to the right with both of my eyes together, that's conjugate horizontal movement, or look to the left, for example, each one is going to be controlled by the opposite part of the cortex. So let's say my left hemisphere, the left hemisphere asks you to move your eyes to the right, and vice versa. The right hemisphere asks you to move your eyes to the left if you want to look to the left. In this case, guys, if I have in the image here, take a look in the image here, I have a right-sided lesion, so that means I cannot look to the left, and so the left hemisphere will take the upper hand here, and it's gonna move my eyes to the right. So I'm gonna look towards the side of the lesion, which is in this case right-sided, right? Because this is not working, this side takes the upper hand and moves the eyes to the right, and that's why a person with MCA stroke looks towards the side of the lesion, right? So in this case, here we have a left MCA stroke, so the person will deviate their eyes to the left because only the right side is working at the moment. That's regarding cortical strokes of the MCA, if the cortical branch is affected. Rather, if the capsular branch is affected, which is the lenticular striate, and in fact this is the most common type of stroke, then the internal capsule will be affected as well. And it's not just going to be limited to monoplegia of the upper limbs and face, rather there's also going to be hemiplegia and affection of the facial nerve. Like I said, because the facial nerve is unilaterally represented. Now, how about the hemiplegia? Why would hemiplegia occur with a capsular stroke of the MCA? This is because, guys, everything is going through the internal capsule. Fibers that ascend and descend go through the internal capsule. So this person is going to be having affection of the sensation as well as motor functions, right? And the optic radiation as well is going through, and that's why we have visual field affection as well. So things are more dense when it comes to capsular strokes. I'm going to show you guys what's going here through the internal capsule. This entire region that I'm highlighting here is the internal capsule. It's divided into several parts because a lot of fibers are going through it. So we have the anterior limb, the geno or knee, and the posterior limb. The anterior limb anterior thalamic radiation conducts the sensory fibers. The genu or knee of the internal capsule conducts cortical bulbar tract, which is the pyramidal tract going to supply the cranial nerves. So if this one is affected, you're going to have affection of the lower face because only the lower face receives unilateral supply. Other cranial nerves will not be affected despite injury to this area because they receive supply from the other side, right? That's the cortical bulbar tract. Now the corticospinal tract is in the posterior limb here, and it's represented just like the homunculus. We have the face, the trunk, the lower limbs in this order like that, as you can see. And then finally, in the most posterior part of the internal capsule, we have the fibers coming from the auditory and visual pathways, so the medial geniculate body of the thalamus, all the way up to the cortex for auditory radiation, and the lateral geniculate nucleus, and then all the way up to the visual cortex through the optic radiation. Okay, guys, and that's why the internal capsule is kind of a condensed fibers going up to the cortex, going down to the cortex. And so because it's mostly supplied by the MCA, you can see here the lenticulostriate artery in blue highlighted here supplies the entire superior portion of the internal capsule, anterior limb, genu, and posterior limb. So you can see here that sensory function are going to be affected, motor functions will be affected, as well as visual field deficits with MCA strokes that affect the lenticulostriate branch or the capsular branch because of supplying all these condensed fibers. The other parts of the internal capsule are supplied by other arteries, and here is the representation. You can see here, guys, this is anterior and this is posterior. Here is the leg, the trunk, the arms, the face. All of these are going to be affected, so that's why we have hemiplegia, right? All of these are going to be affected with MCA capsular strokes. But you gotta know that the face and arm will be affected more, and that's why they were highlighted more densely in the previous picture, because if you take a look here, the lateral portion of the cortex is the origin of fibers of the upper limb and face. And the origin of fibers here in the pyramidal neurons themselves, the pyramidal cells, are supplied by the MCA cortical branches. And so if the main trunk of the MCA is affected, both the cortical and capsular branches will be affected, but you're going to see in the patient's examination that their upper limbs and face are more densely weaker than the rest of the body despite hemiplegia, because here both cortical and capsular branches are affected, unlike the lower limbs where only the capsular branch is affected because their cortical branch comes from the ACA, right? That explains the picture I told you about, guys. I hope this video helped. Let me know what you think in the comments. All the best, guys.